by way of introduction,
Recording in progress.
hepatitis B virus infection is a worldwide health problem, especially in developing countries. It's a hepadnavirus, and it's highly resistant to extremes of temperature and humidity and invades the hepatocyte. It's also one of the oncogenic viruses. It leads to a wide spectrum of liver diseases, ranging from acute viral infections that could include fulminant hepatic failure to chronic hepatitis to cirrhosis and hepatocellular cancer. It could be acute or chronic. So looking at the structure of the virus, the infectious Hep B virion, which is also called the Dane particle, has a spherical double-shelled structure and has a diameter of 42 nanometer. It consists of a lipid envelope that contains the surface antigen, and this envelope surrounds an inner nucleocapsid capsule, which is composed of the core antigen, and then is complexed with the virally encoded polymerase, DNA polymerase, and the viral DNA itself. So the viral DNA polymerase has a unique property, and that's the reverse transcriptase activity. And this is one unique property that the virus possesses that helps them keep replicating and infecting hepatocytes. There are 10 genotypes of the Hep B virus. They are designated A to J. And the type of genotype correlates strongly with the severity of a disease, especially when it comes to genotypes C and D. They are known to be quite associated with hepatocellular carcinoma and a poor outcome. The viral genome of the Hep B consists of a partially double-stranded circular DNA. In some texts, we see it as written as relaxed circular DNA, the rcDNA, and this encodes some opening frames. The surface or the envelope gene, which could be pre-S1, pre-S2, S proteins, and then there's a core gene, there's an X gene, and then the polymerase gene. So this is just explaining what we've been talking about. We can appreciate the lipid bilayer membrane, and on this lipid bilayer membrane, that's where we have the surface antigen, and then within in the cytoplasm, we can appreciate the E antigen, then the nucleocapsid that is enclosing the DNA and the DNA polymerase. So the antigens, the surface antigen is the envelope protein, which we could appreciate. There are different sizes. There's a large, there's the medium, and then there's a small, but they're all surface antigens, and it's specific and is the first marker of infection, and it's detectable in blood. The core antigen is derived from the envelope that encloses the viral DNA. I think we're able to appreciate that, but it's not detectable in blood. Then the E antigen is very important because it's the one that helps indicate whether the individual who has the virus is actively replicating or not, and is one of the things that the virus possesses that helps it evade the immune system. So it's basically this about the antigens and which ones are detectable in blood and which ones are not. In 2022, hepatitis B resulted in an estimated 1.1 million deaths, mostly from cirrhosis and hepatocellular carcinoma. It's estimated that 250 to 300 million people are living with chronic hepatitis B infection, still a data from 2022, with 1.2 million new infections each year. The prevalence of the disease is higher among Black people and persons of Hispanic or Asian origin. Hepatitis B disease not only accounts for 5 to 10% of cases of chronic end-stage liver disease and 10 to 15% of hepatocellular carcinoma in the United States, but is also the dominant cause of cirrhosis and hepatocellular carcinoma worldwide. In areas of high prevalence, where we have prevalence of greater than or equal to 8%, the predominant mode of transmission is perinatal, from mother to child, and the disease is transmitted vertically during early childhood from the mother to the infant. Currently, about 18 million Nigerians are infected with the Hep B virus, and the prevalence rate of 4.3 to 23.3% has been reported in different parts of the country. A meta-analysis of 46 studies puts the average prevalence in the country as 13.6%. And this depicts the level of hepatitis B endemicity in Nigeria because it has exceeded 8%. Hepatitis B infection acquired in adulthood leads to chronic hepatitis in less than 5% of cases, whereas infection in infancy and early childhood leads to chronic hepatitis in about 95% of cases. So you see a lot of the cases we have actually occur during the infancy and childhood period. And this is the basis for strengthening and prioritizing infant and childhood vaccinations. Now, looking at the transmission of the virus, it's basically divided into two. There's the vertical and the horizontal. The vertical, which we already talked about, from mother to infant, which is the most predominant means of transmission. And then we have the horizontal from either blood products, sexual intercourse. So this diagram just shows the different modes from tattoos, tattooing, piercings, using transfusion with blood products that are not screened, organ and tissue transplantation, child to child, especially in children who are less than 5 years, sharing of sharps. So these are different modes that the virus is being transmitted. Now, another important aspect of the transmission is the types of carriers. Now, there are 4 different types of carriers. There are the ones we call the super carriers. And these persons are highly infectious. They have high titers of the surface antigen, as well as the DNA polymerase, and they have elevated ALT, and they are positive for the E antigen, which we already said shows that the individual is replicating a lot. And then we have the simple carriers. They also can cause infections, but you need a large volume of the blood because the titers of the surface antigen is low, and they're usually negative for the envelope antigen as well as the DNA polymerase. So if they don't have a DNA polymerase, which means they don't have the reverse transcriptase activity, and so they are not replicating that much. So that's it about the simple carriers. And then we have a temporary carriers. Those ones just have the virus for about 6 weeks to 6 months. We also have the chronic carriers who harbor the virus for greater than 6 months. And these are the people that move on to have chronic hepatitis B virus infection. And there are certain risk groups for hepatitis B infection: infants who are born to mothers with hepatitis B virus infection, individuals who are intravenous drug users, or inappropriate sexual practices, men having sex with men, and individuals who have multiple sexual partners, people who live with infected persons. That's household transmission, although it's rare, but it does occur. Healthcare workers, they're also at risk, and persons on dialysis treatments are also at risk. So we look at the replicative cycle of the hepatitis virus. We already said that they have a unique property, and that's because they possess the reverse transcriptase enzyme that helps them keep replicating and infecting the liver cells. Now, the infectious virions contain in their inner icosahedral core the genome, which we already talked about. They are relaxed circular DNA, and they are not covalently closed. So in the replicative cycle, there are 3 phases that occur. The virus binds to the hepatocyte via the pre-S domain of the surface antigen. And then when it gets there, it's engulfed by the cell via an endocytotic process. So upon infection, the relaxed circular DNA is then converted in the nucleus of the infected cell into a covalently closed circular DNA. So from the relaxed circular DNA, it moves on, it's converted to a covalently closed DNA. Now, this covalently closed DNA now undergoes transcription and forms several genomic and subgenomic RNAs, which serve as a substrate for the RNA polymerase. So some of them will go on to form the different parts of the viruses, and then it gets assembled again, while some would serve, especially the pre-genomic RNA, would serve as a substrate for the reverse transcriptase enzyme, which would reverse the RNA back to the relaxed DNA again, and then the cycle continues. So this diagram kind of explains all I'm saying. From the viral entry, the virus gets into the cytoplasm, gets uncoated, and then from there it gets into the nucleus. So while in the nucleus, it gets converted from the relaxed circular DNA to the covalently closed DNA. So the covalently closed DNA is now undergoes transcription to pre-genomic RNAs. Now the pre-genomic RNA itself is now acted upon by the reverse transcriptase enzyme, and it forms the relaxed DNA all over again, while some of it goes on to form the other parts of the virus, and then it gets assembled and buds out of the cell. So this is how the virus is able to survive and keeps infecting and reinfecting the liver cells. The pathogenesis of liver disease in Hep B virus infection is mainly immune mediated, and in some circumstances can cause direct cytotoxicity to the liver. The immune system attacks the virus and causes liver injury. This is a result of an immunologic reaction when the CD4 and the CD8 lymphocytes are activated. So they recognize the virus and the particles on the surface of the hepatocytes, and in a bid to attack the virus, also attack the liver cells. But this is not all in the pathogenesis of the disease. There's also a restricted T-cell mediated lymphocytic response against the virus. And this is because there's a T-cell tolerance and exhaustion that is caused by excess of co-inhibitory signals. And also there's a suppression of the cells by high levels of HBDNA and immunosuppressive cytokines. To the clinical features, the incubation period is from 60 to 90 days. 90 to 95% of acute hepatitis will recover within 1 to 2 months. However, mortality in the acute phase is about 0.5 to 2%. 1 to 10% of those who have the acute infection will go on to develop chronic infection. And patients could have acute symptoms or they'll have or be asymptomatic. So they could have the symptomatic disease or have the asymptomatic disease. But generally, the acute phase is divided into 3 main phases: the pre-icteric, the icteric, and the convalescent phase. In the pre-icteric phase, which is also known as the prodromal phase, we have conditions, symptoms like malaise, low-grade fever, anorexia, nausea, vomiting. They could have vague abdominal discomfort, arthralgia, rash. While in the icteric phase, they could go on to have jaundice, dark colored urine, pale stool, hepatosplenomegaly. And in the convalescent phase, which seems like some recovery, that's when they start to develop antibodies against the core antigen. And they could have transient presence of the surface antigen as well as the E antigen and viral DNA, but for just a short period, less than 6 months. And then they go on to seroconvert and have antibodies. But patients who have the acute infection could actually develop complications. They could come in with fulminant or subfulminant hepatitis, and they'll present with in hepatic confusion, coma, ascites. They could have upper GI bleed, and then even coagulopathy. So this is just a diagram that helps us appreciate the phases of the chronic. For those who now go on, amongst the 1 to 10% that go on to have chronic infection, this is their fate. They could either have immune tolerance, or they'll have immune clearance, or become inactive hepatitis B surface antigen carriers, which is also called immune control. A few of them might be unlucky and have a reactivation of the disease all over. But this is what happens. So those who have chronic infection can come to us in either of these phases. Well, examining the patients, especially those who have the acute infection, they could have low-grade fever, they could have jaundice, and this is usually appears 10 days after the prodromal phase. They could have hepatomegaly, splenomegaly, palmar erythema, spider nevi, depending on what the cause is. If it's alcoholic, there are certain stigmata that we expect to see. But those who have the chronic liver disease could come with hepatomegaly, splenomegaly. If there is some form of portal hypertension, then muscle wasting, the hypotenor and the tenor eminences get wasted, palmar erythema, spider angiomas, and even vasculitis, usually for those who have extrahepatic manifestations. Patients with cirrhosis could come with features like ascites, jaundice, variceal bleeding, peripheral edema, gynecomastia, testicular atrophy, and abdominal collateral veins would be visible because of the dilatation of the portosystemic anastomosis in these patients. So this is just an overview of all we've been saying. The patients could have subclinical disease, that's the occult disease, and then from there they could recover, or in some cases they'll go on to have chronic infection. That's why those who have the occult Hep B infection don't just go to sleep. We need to keep monitoring them because they could actually go on to have chronic infection and even hepatocellular carcinoma. For those who have the acute hepatitis, from the diagram here, we can see 1% of them, less than 1% can have fulminant hepatitis and die. Some will go on to have chronic infection and then have chronic hepatitis and develop cirrhosis and then have hepatocellular carcinoma. Some of the patients who have chronic infection might go on to become symptom-free carriers, which we saw. That's the immune control patients. So this just explains all we've talked about. Extrahepatic manifestations could also occur in patients who have hepatitis B virus infection. They could have vasculitis, they could have glomerulonephritis, either the membranous type, the membranoproliferative type, or the immunoglobulin A-mediated nephropathy. Polyarteritis nodosa could also be seen in them, the medium vessel vasculitis. They could have serum sickness-like syndromes where they have fever, myalgia, arthralgia, malaise, and rash. Some might even go on to have polyarteritis. Some dermatologic conditions can be seen, like bullous pemphigoid, lichen planus. They could also have cryoglobulinic vasculitis, and then even Guillain-Barré syndrome. So this is just a picture just to help us appreciate what the cryoglobulinic vasculitis could look like on the left, and then a patient who has lichen planus. So how do we investigate patients who have hepatitis B infection? Some of the blood workup we could do is to do their renal function and as well as their liver function, and then look at the alanine transaminases and the aspartate transaminase, and even the alkaline phosphatase. The alkaline phosphatase can be elevated in patients who have significant fibrosis. So that can actually point towards a patient who is developing fibrosis or cirrhosis. And then even the total protein and albumin are also very helpful. Total and direct serum bilirubin levels can also be checked. Gamma glutamyl transpeptidase levels, especially in those who have alcohol as the predisposing factor. Hematologic and coagulation studies are also very important. The full blood count, ESR, platelets, and the INR, especially when we want to calculate the FIB4 index, which is a risk for advanced fibrosis. Ammonia levels can also be helpful, especially in those who are developing complications like hepatic encephalopathy. And then the serologic test we can do, we already talked about them, is just looking at the surface antigens and the envelope antigens, those who have developed antibodies. So it helps us just place the patients appropriately where they belong. And then we can also do the viral DNA. Some of all of the serologic tests are very important, especially when it comes to treatments, because they are the things we need to check to see if the patient is responding well to treatment, or if they are having some form of reactivation. We can also look at the levels of rheumatoid factor, and this could point towards presence of cryoglobulins. So it would tell that the patient is developing some form of extrahepatic manifestation. In patients who have the antibodies against the core antigen, the immunoglobulin M points towards an acute infection or a reactivation. But those who have immunoglobulin G points towards a chronic infection. Imaging studies also very relevant in evaluating our patients. Abdominal ultrasound, vibration control transient elastography, that's the FibroScan. Abdominal CT, especially if we want to make a diagnosis of hepatocellular carcinoma using the triphasic CT. Abdominal MRI is also helpful if we want to exclude biliary obstruction in acute infection. And then liver biopsy. Liver biopsy is standard procedure, which helps to assess the severity of disease in patients who have chronic active liver disease. Now, the indications for treatment is based on 3 criteria. We want to see the hepatitis B virus DNA, the load, and also look at the alanine transaminase levels, and also the severity of the disease using either the fibroscan or doing a liver biopsy. For patients who have who are E antigen positive or negative and have chronic hepatitis B with viral load that is greater than 2,000 international units per liter, or whose alanine transaminases are 2 times higher than the upper limit of normal, or who have presence of moderate liver necroinflammation or fibrosis, they should be treated. If there's cirrhosis and any detectable level of the virus and any level of the alanine transaminase, they should be treated. And if they have HBDNE levels that are greater than 20 international units, or alanine transaminase that is greater than 2 times the upper limit of normal, regardless of what the histologic lesions are, they should also get treated. So the primary treatment goals for patients who have hepatitis B infection is 1, to prevent the progression of a disease, 1, to prevent them from going on to have cirrhosis, prevent liver failure and hepatocellular carcinoma. So looking at the pharmacotherapy, the FDA-approved first-line agents in treatment of hepatitis B are the pegylated interferon alpha 2A, and is given subcutaneously. We can also use entecavir at 0.5 milligram daily, tenofovir disoproxil fumarate, which is the commonly used nucleotide reverse transcriptase inhibitor, and this is given at 300 milligram daily. We can also use tenofovir alafenamide at 25 milligram daily. This is very important for patients who have renal pathology or who have some bone issues. So it's said to have a renal and bone friendly profile. Its safety profile when it comes to the kidneys and the bone is actually better than TDF. Other second line therapy that we can use, although not preferred, is adefovir, dipivoxil, and delbivudine, lamivudine. Delbivudine is very good for children who are less than 12 years. Lamivudine, not commonly used because patients, while being treated with lamivudine, develop mutant strains and become resistant over time. So it's a drug to mention, but is not recommended. The following medications can be used if we have a co-infection, because patients can actually have hepatitis B and C co-infection. Some can even have hepatitis B and HIV. And some of the drugs that we can use if there's a co-infection between B and C is adefovir, entecavir. We can use the pegylated interferon alpha 2A or the 2B agents. Dietary changes are also helpful for patients who have decompensated cirrhosis with portal hypertension or encephalopathy. And what we can do is to reduce salt intake to 1.5 grams per day, high protein diet, and fluid restriction if there's hyponatremia. Liver transplantation is also an important means of treatment, especially for patients who have fulminant hepatic failure or who do not recover, and for patients who have end-stage liver disease due to hepatitis B virus disease. Now, how do we prevent this infection? For the most important means is actually immunization. That's the best way to eliminate any HBV-related disease. And it's important to know that the HBV vaccination also covers against the Delta virus infection. Now, other measures that we can institute to prevent the disease is to screen blood products before use, which I think most facilities do, except for some quack areas. Avoiding capping of injection needles, avoidance of risky behaviors like parenteral drug use, tattooing, skin piercing, avoid the use of unsterilized instruments, and then prevention of perinatal HBV transmission. So for mothers who have high viral load, it's advisable that before they get pregnant, at least the viral loads, or even before delivery, is to make sure that the viral load is at its lowest, just to prevent transmission to the child. And then importantly, health education. Now, there are new therapies that are being tried, especially if with the understanding of the replicative cycle of the virus. If we have inhibitors of encapsulation, that would help. So even after the virus has transcribed and is forming those particles and is trying to form the nucleocapsid, are there drugs that can prevent it from even developing that initial nucleocapsid that encircles the genome itself? So encapsulation inhibitors can be are being tried, and then covalently closed circular DNA antagonists are also being looked at. There's also the besilfovir. It's similar to entecavir, and then entry inhibitors are also being looked at. Then some immunomodulators like the toll-like receptor 7 inhibitors have been thought to help with suppression, long-term suppression of the DNA. So that's another drug that is being looked at. So in conclusion, hepatitis B virus infection is a vaccine preventable disease that can lead to chronic infection, cirrhosis, hepatocellular carcinoma, and death. The replication determines the level of liver injury and the risk for progression for both those who are E antigen positive and negative. The chronic Hep B virus infection, once it occurs, is only controllable but not curable. Our emphasis should be on prevention of the infection. So these are my references. Thank you for listening.
Thank you so much for that presentation. Okay, so take comments and questions. I don't know, why am I still echoing? Okay, Dr. Justice, go ahead.
All right, thank you so much, teachers, for this echo. Okay, thank you so much, teachers and colleagues. Great job you have done at the presentation.
Okay.
Sorry.
Okay, go ahead.
Let me just mute.
Okay, thank you. I just want to give additions. Let me start specifically with the treatment. So I can know where the questions will go in the exam. Right now, first line treatment are the drugs with high barrier to resistance. That's the tenofovir.
Does everybody have two devices?
I think it's probably a network problem because everybody has
devices on. And mute that device.
Okay, so we use drugs with high barrier to resistance right now. I know you read the guideline that talks about pegylated interferon. Now our first choice, tenofovir base, tenofovir alafenamide, or entecavir. They have a very high resistance, and that side effects tend to be not as significant, and then resistance, and then they are infinite as compared to pegylated interferon, which I think it's at 48 weeks. Right. So we usually present there are conditions where pegylated interferon becomes recommended, like where you have hepatitis B, hepatitis C, co-infection. Yeah, at that point, pegylated interferon becomes necessary. What we think of that one is just like the scenario that you painted. When you start having somebody that has undetectable viral load, and you see derangement in LFTs, ALC, right? So want to think of infection that at which point you do serology, positive the HDV, RNA, and where that is detected. Go ahead and treat. Sorry, I apologize for this echo. I know it's making it difficult to speak. Then I also wanted to mention, in addition to the indications talked about treatment for chronic hepatitis, you must also consider things like family history of liver cancer, chronic liver disease, the presence of extra hepatic manifestation, hepatitis B infection. These actually the criteria for us to treat. Then I want to also mention something about hepatitis C, chronic co-infection. We mentioned that yesterday, which is and one thing was the fact that hepatitis C is curable, and just like you have your goal of treatment for hepatitis is a functional cure, which is either resistance to oppression of hepatitis B, or seroconversion from the antigen, or seroconversion antibody being formed. So usually what the SOGIN guideline, the current SOGIN guideline of 2020 suggests that you treat the dominant infection. And that's defined by the one that has the higher viral. As we are aware, this decision has defined by the fact that one is curable, one is treatable. Then for those that have HIV, I think you mentioned it already. Most of our first line regimen, right now, so you still have to monitor.
Sorry, guys, this thing is not working. We can't hear what people are saying.
Okay, maybe I should just send comments to the group, into the blog.
I would suggest we perhaps shut down the class and reopen it. See what the problem is.
Okay, that would be a good idea.
I think that's the best.
That's good. Yeah.
So I'll close it. We want to lock it.